How's everybody doing?
Very good.
Great. Forgive me, I'm a little under the weather, so we'll see how we do.
It's going around.
Is it? Okay. You guys have the discussion questions in advance.
Yeah.
Mm-hmm.
Right. So what I'm going to do is now just blast through a bunch of facts, essentially, that are, I think, relevant to understand, more of like sort of lecture style. And then we'll talk through the discussion questions. Yeah. Okay. I'll probably do it just because it's how we do it in a slightly conversational way. But anyway, the first part will be a lot of facts, and the second part will be more thinking, I think. Okay, good. So the thing we want to talk about today are, so we did healthcare sort of one-on-one, which is there's payers, there's providers, what motivates them, et cetera. Then we talked about sort of the business and financial model of an insurance company. And now, today I want to talk about sort of how an insurance company practically works. What's the stuff that we got to deal with day to day, essentially. So, number one, so what type of plans does Oscar sell?
Yes. PPOs.
Yeah, so what's that stuff?
Exclusive provider organization, which is like a more narrow network. Then PPOs are more broader, more expensive.
Yeah, so, and then what's the last one? HMO. So, right. So, three different types of plans. We got HMOs, EPOs, and VPOs. And anybody know exactly the Ronan was on a certain path, close? What is the distinction here?
I think EPO has like no out-of-network benefits,
Right, so these two both have no out-of-network, no website or no out-of-network, right? That means other than emergency care, which we're required to pay for legally, but so that means essentially you can build a narrow network. But you can have a broad network HMO as well, broad network EPO. The scale of the network has nothing to do with the plan design. The question is, like, if you were to be out of network, will they pay for it, right? Okay. What's the distinction between HMO and EPO?
I think it's that the HMO you have to get referred to specialists and referred to your doctor.
Right. So typically or historically, this notion of gatekeeping has been the difference. By which meaning where with an HMO you have to get a referral in order to see a specialist. Otherwise you can't. So you have to check in with a primary care doctor. There's a little bit of a confusing thing in that some states don't even sort of like that you just file as an HMO license. It's also a license type, and you can actually sell a plan with no gatekeeping under an HMO license. And so when we actually see HMOs in the market, you actually don't know whether they're gatekeeping or not. And so anyway, that's just the detail. But sort of when we describe them to people, HMO, EPO, GPO, and we are an EPO, which means that it allows us essentially to build more narrow networks. But also we don't have pain in the neck gatekeeping, which we believe isn't useful for member experience. So why can't I build a narrow network in a PPO?
I think the way they involved it was tied to employer-sponsored health insurance, and so in that case, a lot of those plans required more depth. Right?
What do you mean depth? Say more about depth.
Meaning, like if it's the employer deciding the plan or deciding that contract with the health insurance company on behalf of their members, they want more coverage across a ton of different health systems, right? So.
Yeah, well, I guess here my question is, let's say I have a PPO and I go to an out-of-network doctor's office. What happens to me?
It's
Coverage.
So you want out network because you agreed to pay for that.
Well, so does anybody have a PPO now or has had a PPO? So what, I did, I went to the doctors and the doctor typically what the doctor will do is say, well, and let's say it's an out-of-network doctor. Either they don't take insurance or they don't take the insurance you have. They typically get you to pay yourself. They say, okay, you just pay, and then you can submit the claim to your insurance company, right? So, cool. So what's my concern as a member? Right. And so if my insurance company doesn't have an agreement with the provider's office, then I got to settle it with the provider. And if my insurance company only pays half of the bill, then I'm left with the giant balance bill, right? Whereas if the insurance company does have an agreement, then that agreement typically says you cannot balance bill the members, right? So thus, if you have a narrow network PPO, you either are paying a whole lot of bills and charges, like whatever the provider wants, or you are leaving your members with a ton of balance bills to deal with, right? And so that's why typically a narrow network PPO largely doesn't work. It's just like a terrible experience because you just wander around the city getting balance bills, basically, which isn't fun for anybody. And then we have to deal with the regulation of doing it. So typically we don't do that, and nobody else does that. Okay. Okay. So that's the basics, and then what's all this stuff about metal tiers? What is that?
In terms of like the amount of coverage that you have.
Yeah. What does that mean?
So the higher the tier, like I guess gold or platinum, you would get lower. Sorry, it'd be higher premiums, but you would get more coverage in terms of once you hit a certain threshold, that threshold might be lower, and then the insurance company will cover the remainder of your medical expenses, as opposed to if you have a lower premium, it would be, that threshold would be much higher.
Right. I think roughly, don't quote me on this too precisely, but roughly this is it, where you've got platinum plans cover about 90% of the expected care, 80, 70, 60 down to bronze. So that you would imagine, so that when you're in a platinum plan, about 90% of all the spending that may occur, the insurance company's on the hook for, you're on the hook for 10%. Something like that. It may not precisely be that, but that's roughly right. And then I guess you have catastrophic, which is the last group, which is only available to people under 30 years old. So I'm going to ask a challenging question. Brennan, which do you think of these have the higher MLR? Which of these plans has the highest MLR?
Okay, so MLR is basically just a function of premiums divided by medical costs, and the medical costs themselves can be further broken down into like the unit costs, which you negotiate with hospitals, and then utilization rates.
Mm-hmm.
So the premiums will be higher going up, and this question of like, I guess the unit costs are negotiated with this. Well, actually, I don't know.
You pretty much have the same unit costs, by and large, although whether they should or not is a different thing. Because then they got to go balance bill the members. But anyway, so there probably should be lower unit costs, higher, and higher unit costs, lower, because the hospitals have got to go get the money from the people. If the lower on bronze, there's a lot of member responsibility, and the members tend not to pay as often as we do. We pay 98% of the time, the members pay about 25% of the time. So anyway, that's neither here nor there. So in the future, you can imagine different unit costs for different tiers. That's not the way it's worked. Anyway, so unit costs are the same across everybody.
Utilization, I imagine, would obviously be higher. So the question, I guess, is the question of how would premiums adjust for higher utilization rates?
Yes, how do you think that works?
I think I'm trying to think of a way with equilibrium for some reason.
Well, so the interesting thing, so theoretically, you would think we should just price them all to get the same MLR, right? So that I think would be the basic approach, which is no difference, don't worry about it, that the platinum plan should be more expensive than the gold plan, should be more expensive than silver, should be more expensive than bronze. The premiums go up, it's fine, it's cool.
I guess there are probably costs that are non-medical costs that might be higher for some of them. administrative costs for administration.
Yeah, but like, yeah, you could maybe say the admin would be like this, you pay the same $50 PMPM to administer the plan, so maybe percentage-wise or whatever, but that tends to, it's a little bit of factors of such that, for example, Medicare Advantage, the MLRs tend to be higher because the premiums are so high and the admins are low. Anyway, but actually, I'll ask this. Yeah, go ahead.
I was just gonna say that, like, regardless, even if you try to hit the MLR equal on all the plans, it's mostly just dependent on the trends of, like, what's happening with platinum versus bronze, right? So, like, if I take bronze because I never get sick, then your MLR will be lower. That you'll be making more off of me than someone who gets sick frequently and maybe has to get the platinum plan. But then,
So, yeah, so okay, interesting. So then Zishan's saying, well, listen, all the sick people are going to get the platinum plan. Like, if I know I'm really sick, we have the platinum plan. And if I know I'm probably not that sick, I'll probably get the bronze plan. So the bronze, like, another way to put it is, you'd imagine, well, the platinum's going to be even higher priced than the bronze. So you can imagine this just being like a 10% difference. This is 10%, this is 10%, this is 10%, you know what I mean? I think to Zishan's point, that you would say, well, no, the platinum plan should be more than 10%, like more expensive than the gold, because people will select it, all the sick people will take this one, and these ones should be very lowly priced, because all the healthy people take this. Does that make sense?
because essentially, if I know I'm getting, if I have tons of medical expenses every year, but your platinum plan is only 10% higher than the, like, gold, then, you know, like, it just seems like a no-brainer to go after that plan. Because I'm probably going to hit whatever thresholds are required and get you guys to cover my healthcare expenses.
Yes, so what do you all think?
And I think it outweighs the difference of, like, the pricing.
Yeah, I agree.
There's also something though about if you're out of Medicaid, this is your alternative. So most of those members are not going to have the funds to be buying platinum. So bronze, whilst it's only 10% difference, 10% difference in that like group of people is a lot. Generally, sicker people come from like lower financial resources. Generally, leads to sicker people in that group. They don't tend to take care of themselves as well. So I think bronze would be lower.
Ooh, well, there's certainly a thing that the subsidies work on, and so we're now going a little out of order of what I wanted to cover, but it's fine, I'll cover it. So the subsidies are based on the silver plan, the second cheapest silver plan. So we'll talk about the subsidies in a second. But anyway, that's a relevant thing, and so if you are a low-income person, you can usually get a free bronze plan, depending on which market you're in, but usually you can get a free bronze plan, and so that could be a very appealing thing for you. That tends to a little bit water down what Zishan was talking about, because there can be quite ill, cheap people with low income, and then that's likely where they would go. The correlation between income and sickness and health is actually is not as big. It gets watered down that way, but it's mostly, you still have the things you touched saying, but platinum people tend to be a lot more sick. It's just the way it works out. Platinum a lot more sick, bronze a lot healthier. But now, so what's this thing, risk adjustment, and how does that play into this?
Where insurers that cover more risk-heavy populations have to, or they are subsidized by insurers who don't cover as risky populations, right?
Mm-hmm. Right. So in essence, that works a little different in Medicare Advantage versus individual. It's largely ends up not really mattering. But in the individual market, essentially, if you have any person who's sick, per person who's sick, you get essentially a certain number of points. And for a person that's well, you get minus a certain number of points by and large. And at the end, you net all your points, and you get then all the people with positive points get money back, and the people with negative points have to pay money in, right? And they just swap the money. In Medicare, just the government pays you per sickness person that you have, so it's just all net out from the government. But in reality, it's still just a competitive marketplace, so it doesn't really much matter. It's just where the money flows, it doesn't really much matter. So then how does this make you think about this? Does that matter for this? Dushan, to your point?
Well, doesn't the risk adjustment factor, does that go into your standard MLR that's like reported everywhere, or is that like a weighted, like a different weight, or a different type of MLR that's like considered, or and like which is your question like specifically about like if that's true, then is it about the standard or like the weighted?
Well, I guess my question was, so there's this risk adjustment program, which seems to me not get paid more for the sick people.
Mm-hmm.
But you were telling me that I need to charge more to the sick people because they're more likely to get a bunch of care. And so I'm wondering, wait, is that true anymore? Do you get the question?
Yeah.
We've paid historically. We aren't benefiting from, our population is healthier.
Mm-hmm.
So that is going to have a big difference. Because we're getting the people that are buying probably the lower plans because they are healthy and are not using our care.
Right. So there's this notion here where like you might think that there's this thing, negative selection or something like that. Oh, I'm in platinum. Okay, I got to really increase my prices on platinum because everybody who's going to use it is going to be sick. Right? That is mitigated because you get a increased revenue from essentially from the government or this government mandated program from all the people, the healthy people. So you get somebody who has whatever, whether it's diabetes or whatever, any like cancer, etc. Okay, I have cancer. You're going to get $50,000 in the mail for managing the care of that person. And then the question is, well, are their claims more or less than that extra $50K? You get what I mean? So that's the essence of the risk adjustment program, and it's a really important one for how we work because individual and MA and small group are all risk adjustment markets.
I have a question about risk adjustment.
Yeah.
So is it based on we insure someone who has diabetes, or we insure and pay claims for someone who has diabetes? Do we still get the money even if they don't cost us anything?
We have to have some evidence, typically a claim, or from a doctor that has a diagnosis code with them having had diabetes, or doctor's notes that are very clearly say they have diabetes. And so typically they have to make it to a doctor some way, shape, or form.
So then sick people in the platinum plan are way more likely to be identified as having those conditions.
Correct.
And therefore, help the insurer in the risk adjustment program.
Right. And so then there's the question essentially, is risk adjustment over or undercompensate you for the health of the people? You get what I mean?
So is your question like, is the risk adjustment payment appropriate given?
Yeah, I'm not necessarily asking you because that's a very detailed actuarial question, but that is a question that is really relevant and important when you're choosing which markets. When we build networks, do we want to have a network that looks like the Cleveland Clinic network, which has a lot of sick people and a lot more go platinum or whatever, or do we want to have a network that looks like Tenet Network, which is skinnier, cheaper, etc., draws a lot more bronze, silver, right? Well, it's important to understand, certainly if you're going to price in those markets, but also if you're going to build the networks, how much of that, and does the risk adjustment accurately compensate you or not, or what's the deal? The current house view, which we're sort of learning and evolving, and Cleveland will be a good case, etc., is that it's about fair. So you don't have to worry about it. What happens a little bit though, so risk adjustment, so whether you would rather have a sick population or a healthy population, it's relatively fair. However, the worst is to have a healthy population that is just about to get a bunch of care. Such as I don't know, Cole just had his ACL torn or whatever. Healthy, looks at the healthy, but now he just goes and gets surgery or whatever it is, or it gets hit by a bus and there's a trauma, or whatever the things are. And so for the folks, so I think the way it turns out a little bit is that the platinum plans end up being getting a little bit negatively selected for that reason, because they get platinum and gold that people sort of jump in knowing that they're about to get some treatment for something, and they select into that thing. So it tends to be, at the same time, regulators and pricing don't allow us to just totally jack up the price in the platinum plans. And so our MLRs, typically, this is not 100% true, et cetera, tend to be a little higher on the platinum and gold spectrum, much fewer members there. And then the MLRs on the silver, bronze, and actually catastrophic, we make money hand over fist with MLRs like in the 50s, 60s, or something like that.
But that will really change next year though, right?
Why?
Because of the individual mandate. Like, aren't we the perfect plan for all of the healthy people that have to get a bronze plan to comply? And next year they could back out. And then that will shift the whole dynamic?
Well, let's see. So I guess my aggregate thought is individual mandate, probably not the biggest deal for this market. Like, I think a few people will drop, and yes, they're more likely to drop from those, although as the prices go up, there's also more likely to be people from platinum and gold buying down. And so both of those are going on at the same time. So I don't quite know what that will mean for the metal mix or whatever. I think the market will go more towards people who are either subsidized or sick. And that's kind of where the market will end up. But exactly how that plays into the metal mix and the pricing, anyway, maybe ask Fausto, who may have better views than me. I also aggregately have views the individual mandate is not the biggest deal because it's already, we'll talk about in a second, is the subsidies. Okay, so does that all make sense? So we got plan design, we got metal tiers, okay? And we have the risk adjustment, which is what I want to talk about later, but fine, risk adjustment. So now let's hit the subsidies here for a second, make sure everybody gets it. So does anybody know how the subsidies work? I'll basically give you the details of the facts. But basically, it's something around 400% of the federal poverty line. You start to get a subsidy. And what it means is that you can at most pay a certain percentage of your income. And that income, the percentage, and it's a different percentage the lower the poverty line you go. And what it means is that you then prove, say, I have this income. This is what I made. This is my W-2 last year. Maybe I make $50,000, which is 250% of the federal poverty line or something like that. There's a table and it says you can at most pay 7% of your income or something like that for health insurance, right? Then they look at the price of the second cheapest silver. They compare that to that 7% of your income and they give you the difference, right? And then you can take that money and buy any plan that you want. You can buy a platinum plan and come out of your pocket and pay more than 7% of your income, or you can buy a bronze plan and pay less than 7% of your income. Yeah? Does that all make sense? And that's so, and it's about, about 60% of the market or so, 65% is subsidized. So, now, given what I just said, let's say all the insurers in a marketplace raise their prices by 25%, year over year, and I'm a subsidized member. What happens to my premium?
It'll go up, and your subsidy will get larger because you can't pay, like your component will stay the same, right? Like you can only pay 7%, but the premium will go up.
So what do I experience as a person?
I guess very little change, but depending on like your benefits and the prices of other care that you like, copays might be going up as well. Or do the subsidies kind of factor in like all the member responsibility, or is it just premium?
Yeah. So the first point which I want to hit is generally nothing happens. I'm capped out at 7% for my monthly premium, like of my income. So if the prices go to infinity, I'm paying 7%, and the government is paying the rest. Okay, and the detail in the question you're asking is because the silver plans are targeted a certain percentage of average annual value. Like you can't. It's not like the insurance company's going to be like, okay, now that's your responsibility. It has to be a silver plan, and a silver plan is a certain percentage of member responsibility, co-pays, co-insurance, etc.
Okay.
You know what I mean?
Yeah.
So, and that's actually a really critical feature, and I think it's the only feature. It's like the critical feature that makes Obamacare work. And if they change that, like the market's going to be screwed. Because what's happened over the last 5 years is that premiums have almost doubled. They've gone up like whatever 60, 70% more. Depends which location. And yet a few people have dropped out, but a whole lot of people have not dropped out. Why? Because they have not experienced any price increase. And so this is the classic insurance death spiral. Happens in every type of insurance, not just health insurance. The prices go up, the people who don't need it drop out, the people who really do need it stay in, then the prices go up even more, then even more people drop out, and you're left with the people who like fire insurance, you're left with the people who are about to light their house on fire, or whatever. And so that dynamic is what always happens in insurance, but it is not the case in the way the individual markets work, mostly, for at least the 65% of people who are subsidized. It's a really important thing, and if you look at, for example, and I'm not making a political statement here, but you look at the Republican plan that was going to be put in place, it was going to have the same dollars of subsidies on average, but it was going to cap exactly how much each person was going to get, $2,500, right? And if you go to a world where you're getting $2,500 versus a capped percentage of your income, my personal view is the market will blow up. Because if we go to underwrite premiums, we don't know how many people are going to drop off the exchanges. And when that happens, we have to price really high to be safe. That means even more people are going to leave. That means we have to be even higher, and so there's almost, you can't price it to a certain degree, right? And so that I think would have been a disaster for the individual markets. Again, it's not a political statement, it's just a personal view. But that's a really critical way to this market functions. And what you're seeing is that in the individual market, the percentage, do people know what on exchange and off exchange is? That as well. So on exchanges, there are these Obamacare exchanges. Most of them run federally, but a few run by individual states. California is an individual state. There's other ones, Michigan as well. Anyway, about 70% of the membership goes to the exchanges. You can also sign up off exchange. So you can just go to our website and buy health insurance. That's cool. It's actually cheaper for us because we don't have to pay 3% of premium in taxes to fund the exchanges. But anyway, and you can also go through a broker who would just sign up directly with us, etc. So it's about 70% on exchange, I believe, and about 30% off exchange. If you are off exchange, you cannot get a subsidy. If you're on exchange, you can get a subsidy, although you may or may not be eligible. Okay? So the off exchange market has been shrinking pretty fast because it's all of the people who are paying without a subsidy. So the ratio, the percentage of people, it used to be like 50-50 on and off exchange, now it's like 70-30 because the people who are going off exchange are not subsidized and they're experiencing all of the price increases that have occurred. Make sense? Okay, so that is subsidies. Good. All right. So what do we, we'll hit quickly. What does it mean? What are the different forms of member responsibility?
Copay.
Copay. All right.
Insurance.
Copay, insurance, deductible. And so what are the three different things? What are these three things?
So copay is you may pay $10 per visit to a doctor's office. Co-insurance is where you will pay a percentage of the care or whatever you have. And deductible is normally a fixed amount you have to pay before the insurer starts paying for your care.
Right. So basically, the basic way it works is you go to the doctor's office the first time. No matter what, you got to pay your $50 copay, and then the insurance company pays the rest for those doctor's office visits or whatever. Typically, like office visits and primary care are not subject to your deductible. But then you have this thing called deductible, meaning that you are on the hook. Like if you get a surgery, for the first $5,000, you're paying for all of it, essentially. And then for some, the next bit after $5,000, there's a co-insurance, meaning you pay some and the insurance company pays some until you hit your out-of-pocket maximum, which is the other out-of-pocket maximum, which is the most amount that you can pay in a year. Okay, and so those are more or less the concepts when we do the very basics of plan. There's a lot that goes into plan design, but those are some of the things we deal with. We have got more or less the two main things that we have is called a simple plan and then a classic plan. A simple plan, the basic feature of it is it has no, I believe this is right, that there's no co-insurance. And the deductible and the out-of-pocket maximum are equal. Meaning, it's just pay $5,000, you're on the hook for $5,000, we're on the hook for everything after that. And sort of keeps life simple. There's still co-pays as a part of it, but it sort of keeps life simple in that regard. And it actually, the details, but the average annual value of our plans for simple plans tends to be a little bit lower. The average actuarial value tends to be lower for simple plans, so simple plans tend to be a little cheaper than classic plans. It's a detail, but okay. So that is that. What else should we talk about? So let's just go through literally like what happens in care. So like let's say I was playing a game of hipster kickball over the weekend and I slid into second base and I heard a pop and my knee is really swollen and it hurts. What happened? Let's like literally walk through my life cycle as a patient and as a member and make sure we get sort of the basic pieces of what happens. So what's the first thing that happens?
You have to,
What's that?
you have to decide to seek care.
Okay, and I say my knee really freaking hurts, which I do. I should probably go see a doctor. So I walk it off for a day or two, but that really still hurts. Okay, so then what? So let's start with the problem. Problem. And then I want to seek care. Decision. I decide to seek care.
So it kind of depends on the kind of person you are, as to whether you will phone your health insurer to say, hey, I need to get care, can you help me? Or I'm going to go to the emergency room because my knee hurts.
Okay,
Or I'm going to go to the doctor.
Well, but everybody, like, so what are you doing in that activity? What is that activity?
Evaluating options.
Seeking care, I guess.
Yeah, you're searching for a provider, right?
Yeah.
Like, you're searching for a provider. And a provider could be your local emergency room. You essentially have to, or it could be choosing an orthopedist, or so you have to choose the type of provider, and then you have to choose the one you want to go see, right? Okay, so let's say I go to whatever, my hipster primary care doctor, and I go, and I say, hey, my knee really hurts. Then what happens? So I literally I go schedule an office visit, let's say.
So that provider should check whether you're insured or not, and then if you are insured, whether you're in network for.
Right, so they essentially confirm your eligibility. Okay, so they call, and that literally means calling, and saying, hey, is this person a member? Okay, and let's say I need some weird injection in my knee. Then what happens? They're going to do, I don't know, cortisone injection in my knee, probably a dumb idea, but let's say they want to do that.
Check coverage.
Okay. So,
They'll probably
what are they
inform you.
doing? What are they doing then?
There, I guess,
So let's make it an MRI with contrast, because that's fine. And a little more clinically reasonable. I'm going to get an MRI with some contrast.
they're gonna probably call and see if the service is covered or if you need prior approval, like prior prior authorization.
Covered, right, so they essentially, they're gonna do a benefit check. And what are they interested in when they're interested in whether it's covered? Anything else?
The rate,
Yeah, so what do you mean by the rate?
that they'll be reimbursed for rendering that service.
Yeah, I think the big thing that they wanna know is, do I need to charge the member?
Yeah.
Now, like, does the member have a copay, co-insurance associated with this thing? Whether it's injection, whatever it is, like, is there a copay, co-insurance, or do I have to go get something right now from the member? And they're obviously interested in that because they on the back end, will adjudicate the claim with them, and they don't know, and you might know this as well as I do, but they often don't ask us for what their contracted rate are. They just need to, because they know that'll get dealt with on the back end, they just are trying to figure out whether I need to get more money from the patient right now, right? So, that sort of all goes into the check benefits process of, is it covered? If so, what is my co-insurance, blah, 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 okay? And then, okay, so, now let's say the doctor says, oh God, you know, and let's say I go get my MRI, I, by the way, go through the same process here of going, finding one, et cetera, you know, making sure I have insurance, et cetera. Now, MRI comes back, and they look at it and they say, oh man, you need to get ACL surgery. Then what happens?
Is it urgent?
Not urgently.
Okay, so then that's prior auth for sure, right?
Well, so what does that mean?
So there, the ACL surgery has a CPT code, and this Oscar doctor puts it into our provider portal where it then says, need prior auth. And I guess one thing, like a nuance, is you have to figure out, can that doctor do it, and can that doctor do it there? Like, do you have to go to a different facility?
Yeah, so we have something called clinical review, basically, CRT, routine medical review, et cetera, a few different names. But, and basically what their job is to say, is this medically necessary? And they also check to see, like, making sure everybody's in network. So that if you're going to do it out of network or something like that, they say, no, you can't do that procedure at that hospital. Okay, good. And then now, or also, by the way, utilization management, et cetera. So, and when, as a detail, like some of these things are the things that really, you know, upset providers and are a pain in the neck. So if you're like a doctor and you're like, I need to go spend an hour on the phone convincing a nurse at an insurance company that this MRI is really necessary when it's obvious that that they need for an MRI, that's a pain in the ass. So anyway, when we think about integrations and such, some of that is around these sorts of topics. Like how do we actually make life easy for them? Okay, of course, on the other side, we have to do clinical review because otherwise everybody's going to be like everybody in the grandmother's be getting an MRI, right? Because you're like, okay, MRI, I'm making an MRI. Well, let's do 10 of them. Why not? Like, you know. So anyway, it's an essential thing, but it's a challenge. Like it's a big pain in the neck for both sides to get an agreement on that. And so the things we're trying to work on is how do you lower that without people going wild. Okay, so then basically what happens is then I get surgery, right? Okay, so what happens after the surgery?
You get hit with the first bill.
So what does that mean?
The bill that you get from the hospital or doctor that you were visiting. The first bill, I guess, maybe 3 potential bills.
So yeah, I'm a doctor. So what I just did your ACL surgery. I did a great job.
Yeah.
You did great. What do I do?
You work with a team of other providers, so nurses and other specialists, to deliver that care.
Well, yeah. Well, I guess what do I after that? How do I get paid?
What is the code?
Submit claims.
So I submit a claim. Who do I submit the claim to?
Clearinghouse.
Perhaps, or anyway, to the insurance company, basically. That goes, excuse me, a clearinghouse is sometimes not. But anyway, but the member has not been billed yet. That's the important thing. So the member doesn't get billed, you go to the insurance company first, right? And then what do? Okay, so
Eligibility, which pay benefits.
yes, so in essence, we do take a claim, which we adjudicate the claim. We're checking whether it's our member. We're checking whether this is a covered services. We're checking whether they've gotten received prior authorization. And then what else do we do when we adjudicate a claim? Right, so we have to know what we're supposed to pay, and then we also have to run it through the patient responsibility. Right, so those are the basic steps that we do. We just say, okay, is this our member? Is this a covered service? Was it medically necessary? Did they go through all those steps we have to do? And then we get the rate, and then we decide how much should the member pay, how much should we pay, right? And we can do that either automatically or for more complex cases, we have to do it manually. And a lot of that, like, often happens at a line item by line item basis, because if you get these long claims, it's one thing if I just get one CPT code and I can know it, but you get, a long, 10-day inpatient stay, and there's a whole lot of stuff in that. You have to decide, well, which one of those things was medically necessary, wasn't medically necessary, et cetera. And they'll also go through, which we'll talk about in other classes, some of the bundling logic in terms of adjudication. So if let's say there's again, we'll get into other classes, but there's a case rate for your appendectomy, which covers imaging and labs and everything in it, but you separately billed me for imaging. Well, I'm going to deny the line item called imaging, and I'm just going to pay it all under case rate. So all the bundling logic, all the payment policies, all of that stuff is what Aaron, et cetera, as well as the claims team work on. And so adjudicating claims is a relatively complex exercise, particularly for anything that's a non-trivial claim. Okay, so then what?
Pay the provider and send an AFP.
Right. So we send essentially like a check, sometimes electronic or whatever, plus EOP, right? Not my acronyms here. Meaning we send an explanation of payment to the provider. And we send an EOB to the member, explanation of benefits, right? And this is, both of them say, just in different terms, hey, this is why we paid you this, and then this is how much we paid, and this is how much you owe. Right? Okay, so we good, we done? Anything else happens?
Dispute.
What does that mean?
The hospital's not happy with what you said is appropriate.
Okay, so what do?
They then push it back, and then it gets escalated for a change.
Yeah, so there can be optional dispute. So what is that? So what happens then?
An office manager will call in, and then provider relations usually ends up getting it, and then it gets escalated to claims to review. Was it adjudicated correctly? Then sometimes clinical review team gets pulled in, sometimes it's a contract thing, so it goes through our workflow.
Yeah, so a bit depends on the nature of the dispute. If the dispute is, like this claim was denied and I don't think it should have been, that's sort of a claims question. If it's, you denied this as medically necessary, but we think it was, you go back to clinical review. So it sort of gets triaged across a bunch of different, or if it's just, we interpreted our contract differently than yours, that's a claims issue. So there's a whole swath of things that can happen under the umbrella of, I'm a provider and I want more money. And so it gets triaged and then handled with the right person, okay? Yeah.
This can't get resolved. Do they most often go to arbitration, or is there some regulator that handles it, or is it like litigation? Or?
Yeah, so there's dispute resolution, which is basically we have to get in a room in a formal process and like work through the issues. What usually happens is we then decide, like, okay, yeah, we were right, you were right, we're wrong, whatever, and that resolves a lot of the cases. And then a few that are not, there's a formal process called dispute resolution, which I'm not the expert in, but you have to essentially get in the room and decide and discuss and decide who's right or whatever. If you still can't resolve it, typically what happens with major health systems is that we do essentially a claim settlement, where we kind of just agree not to sue each other and just like, we'll write you a check for $500,000, just like, let's not get the lawyers involved, more or less. And so, and usually with the health system, it's like, here's 300 claims. Our team says this, your team says that, and it's kind of just like, let's pick a number in the middle and write each other a check and be done with it. That's pretty much what it is. And sometimes you throw like, and then everybody throws like their kitchen sink of other relationship asks they have at the time. Like, well, we want to change this contractual provision. If we're going to pay you that, blah, 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 blah. And so it's like a real pain in the neck. And largely, that's kind of what the network team does at other health plans. Is like they just sort of bitch and fight with providers, and they settle these huge like claims, disputes for $5 million, $10 million, $50 million a year or whatever. And they just, that's it. Because there's no new networks to build, and the network rates are kind of the rates. And it's kind of, there's no expansion, and so they just fight with each other, in essence. So, anyway, it sounds fun. So anyway, that's, and then if we still can't get into sync on that, then we can sue each other, and then you go to courts, and like, I've never had personal experience with that, but it doesn't sound like fun. And different states have different processes for resolving those. Some will have more mediation processes, some will have, some just, it's like a lawsuit, essentially. Often it's a lawsuit. So the vast majority don't get to that place, and usually you end up in a court case if there are fundamental things like, this person's, Anthem is like changing what they pay as ER, and they're just denying a bunch of claims as non-emergent or whatever. Well, if they stick to their guns, they're probably going to get sued, and then they'll get sent to that in court or whatever. Or out-of-network is another big one where there's not a clear decision of how much we should pay. So it's much more like, all right, well, we'll just see in court, that sort of thing, because there is no record, essentially. In-network rates tend to be a little bit easier, although still there's a lot of issues with what's medically necessary. Okay, well, I didn't think that was medically necessary. But the magnitude of that tends to be a bit less. Okay. So that's kind of just like what we do. Okay. So I'll just have to go through a few of these questions. So Oscar's MLR, higher or lower in the first half of the year?
Lower. Yeah.
Why?
People haven't met their deductibles yet.
Right. So mostly because at the stage of adjudicating a claim, that more of it goes on to members. Also a little bit because people don't, there's actually less utilization earlier in the year because people are afraid of their deductibles, and then they blow through their deductibles, and then they have a big healthcare party. Essentially,
That's probably a very small factor, but do we find we have greater influence on the actual utilization rates throughout the year as we get more data on providers and patients, or is that like?
Well, certainly if you, like new markets, we don't know as much. So we don't have cost scores really on new providers. We don't know provider behavior, so our ability to save money by route of care is much, much less, as to say, from more mature markets. I don't know if it's really all that seasonal. I think a little bit early on in the year, we have the big thing, I think our care routing share looks like a little bit more in the beginning of the year and a little less later because everybody joins Oscar, doesn't know which doctor in the network, and gives us a call and says, okay, how do I find a doctor on this plan? So I think there tends to be a bit of a spike in the early part of the year as people seek care, and then later on they already have their doctor and they figure it out.
Do we also see an impact in the later part of the year because members get close to the end of the year and they're like, I'm not going to pay these last 3 months premium, I'm going to be fine?
Yeah, so then people leave. Yeah, I think it's something like, I think it's like 5% of our people leave every month or something like that. Maybe that's too high. Maybe it's like 2-3%. Anyway, I don't quite know the number, but certainly there's a meaningful attrition. People just stop paying their claims for whatever reason. Though the bigger deal is whether they're on electronic payments, it's forgetfulness. Like the single biggest factor is, do we have their ACH records, which is a big thing for member services to up that, because if we have that, then people end up paying because they're just, whatever, Okay. We have 5 minutes left here. So what do you think about the idea that Oscar can meaningfully lower healthcare costs? This is a challenging one. by offering financial incentives for consumers to go to lower healthcare lower cost alternatives. And for what types of care would this work and not work?
I think it depends on the incentive. I mean, is it coming in the form of, say, like gift card or lower premiums?
Well, I mean, I'll turn that around to you. What do you think would work or not work?
Well, I guess it would just depend on like what you're trying to get. Like, you can convince me maybe to go get a checkup, and if you give me like a $50 gift card, that seems like worth my time, and like just seems like something I should do. But like, you don't always see like the effect of the lower premium like right away. So maybe that is something where you need like a bigger, like if I'm just getting checkups, then yeah, of course, like I want lower premium, but I'm not going to see that right away. So just trying to understand like what that financial incentive is in order to.
Yeah, I think presumably if we just lower your premium, you're not like incentivized to choose Dr. A or B if your premium is lower. You just get that premium and whatever. So you want something that somebody is incentivized to change their behavior as a result of, right? I think. And so yeah. So what's the sort of care that we like? Like what's the sort of care that you think people would change their behavior for?
I think it's got to be something that's kind of like non-emergent, kind of like pre-planned, where you can explore all your options and kind of realize that there is that incentive to go somewhere else that may be less expensive. Just because it's hard to kind of know what you actually are going to have to pay before you get a service done from a member perspective.
Right. So obviously, like the thing you probably can't do anything about is emergency care. So you get hit by a bus, you go somewhere, like there's no ability to shop that. Like you're just there. And that that tends to be about 30% of all care or something like that. And not just emergency claim, but all the inpatient care that goes along with it, and discharge, blah, blah. So more or less that's about 30%. So like that's off the table. What else? So what other impediments are there to sort of providing incentives to folks?
Well, it doesn't really make financial sense for us, I'm assuming, to incentivize Zishan to go get a checkup, a healthy, like, young person. But like if I'm predisposed to 5 things and I haven't gotten a checkup all year, then it's an incentive, like that's worth $25 because maybe I show up and I get diabetes added to my chart and then I'm risk adjusted or whatever. So I think you're doing a subset of the population that isn't already seeking care, or like in Megan's example, she needs that procedure, then you can direct her to a cheaper one for us.
Yeah, so should Oscar pay everybody for their annual checkup? Why not?
I could discover that I need something. I mean, well, that like I guess it just depends on the person, but some people once they get to the doctor might be more inclined to take advantage of their health insurance for minor things than just health insurance.
Well, and the other thing, like, so we have to decide whether we want everybody to get a checkup or not. Like, I think it's probably not that great for healthy people because then they find a mole that doesn't look good and who knows what they're going to get. And so it's actually not a great trade for us. And also, people are going to do it anyway. So if you start paying people to do things they're going to do anyway, you have to factor that in. And then, and then the other things we have to think about as we do plan design is there's also a lot of care. Like if somebody's on a particular drug, they're obviously not going to want to shop that generally. You could shop generic equivalents, whatever, but that's there's a lot of specialty drugs that people are just on, and that's what they cost, and boom. Also very sort of severe conditions, like if somebody has cancer, like I'm not going to offer them like $50K to go transfer to a different hospital. Like they probably just want to go where they're going. And so all of that gets in your way. And also in our current plan design, the vast majority of the care happens for people who are through their deductibles. And so that becomes an issue. So, okay, if you're through your deductible, I don't care. Like, so I literally got an MRI and Cigna called me and said, would you like to go to a cheaper MRI facility? It's a mile from your house. So, well, that's great functionality, Cigna, thank you. And how much is it? Well, the one you're going to go to is $750. This one's $400. Would you like to go book an appointment? I said, well, what's the deal with my deductible? What's my responsibility? They said, well, a lot of times on hold. And then they said, yeah, you're already through your deductible, so it doesn't matter for you. And you're like, okay. So then I don't actually care where I get my MRI. So anyway.
Isn't there something about in what we're doing by looking at doctors who are high quality, high cost, that actually, if you phoned me and didn't mention money, didn't tell me you were going to give me anything, but said, hey Adrian, if you go to this doctor, they've got better member satisfaction scores than the facility you're going. We care about you, we want you to get the best service. I believe this place is the best for you to go. I'd go.
And that's why, to a certain degree, that's one of our approaches. Is you don't have to necessarily pay people, but you can just have, like, for example, if somebody called me, if I knew I could go on the Cigna app and book my MRI online, and there was a cool MRI, like I wouldn't really care about all that other stuff. And so that's a little bit about how we choose scheduling for doctors. We pick the doctors who do a good job, and then we make it really easy to get to them. And as long as we're picking high quality as well, we're not sacrificing quality.
Yeah.
You can get great quality cheaper, and for a lot of people, it will be cheaper because they won't be through their deductible. And hooray, everybody wins. But this notion of shopping is a challenging one. We're going to try to explore it in the future, but it is a challenging one because a lot of care doesn't, there's not the financial incentive naturally in the plans, and then you start to get to weird things where you start paying people to go to surgeries. Like, okay, if you go to this surgery, you get your ACL there, we'll pay you $5,000, and that gets weird incentives because people just hurting their knees for fun and whatever, all sorts of stuff. So anyway, that's an area you have to sort of tread lightly, and there's also regulations as a result of that. We're not going to have, I don't know, we'll just pause on the other two because they're not mission critical, and we hit the high level stuff. Any final questions? Okay. All right, it's useful.
Yeah, definitely.
All right, good, thanks.